science and the use of EPAs. Contemporary pain science suggests that pain acts to protect the integrity of tissue rather than monitor the status of tissue damage. That is, hurt does not always mean harm. So the biopsychosocial model is a model that demonstrates the understanding of contemporary pain science and how pain is not just biological but also psychological and social. So the model views pain based on interactions between biological, psychological and social factors of a person and their condition. The model demonstrates that every person experiences pain differently for many biological, psychological and social reasons. So nociceptive or peripheral dominant pain involves bottom-up peripheral drivers that receive sensory input from somatic tissue. This pain is experienced due to a fast mechanical source such as a hit to the body or severe hot and cold sources such as a hand on a stove. If serious enough, this pain may lead to peripheral sensitization in some people. The location of nociceptive or peripheral dominant pain is precise and concentrated that does not spread. The type of pain can be sharp, blunt, dull or achy that is extreme and will worsen with movement but lessens with rest. The patient often describes clear aggravating and easing factors. The withdrawal reflex is related to this pain, while the type of pain and duration reflects the seriousness of the injury. Clinically, the pain is associated with an injury that has occurred within 3 months. Supraspinal central driving pain is different as it involves top-down processes from after a longer period of symptoms and a change in the nervous system, including the dorsal horn and psychosocial stimuli. The location of supraspinal central driving pain changes as it moves around and is not a localized pain. The type of pain is unusual and not a precise description compared to peripheral dominant pain, as patients will often use analogies to describe the pain. The pain is severe, however, is not influenced by movement and does not ease with rest. Clinically, the pain is not linked to a clear mechanical driver, but there is an association between the pain and psychosocial factors. Heat has many therapeutic, physiological and mechanical uses. Heat is used for pain relief, reduces muscle spasms, increases range of motion, increases cell activity and blood flow, thus promoting healing post the acute injury phase. Other uses include reducing the viscosity of thick fluids and nerve stimulation for pain by providing an analgesic effect. The proposed mechanism of action for reduction in pain is parasympathetic influence, afferent nerves, and the pain gate theory. There are many contraindications and precautions when it comes to using heat as listed on the slide. Before using heat as a treatment, a thermal sensitivity test must be performed to determine if the patient can differentiate between hot and cold on the treatment site. TENS treatment is effective as it is an easy-to-use treatment for acute, chronic pain and pain associated with cancer that produces minimal side effects. TENS involves electrical currents generated by the machine to stimulate nerves via conducting electrodes on the skin. TENS is more effective for acute pain as the effect of TENS treatment occurs during the stimulation of the nerves and has a minimal long-lasting effect. However, TENS can be used for as long as needed. TENS also involves physiological and therapeutic effects, which include selective depolarization of various nerve fibers in the skin, as well as decreasing pain through the peripheral and central nervous systems. The proposed mechanisms of action for TENS include the pain gate mechanism and the endogenous opioid system, which aim to stimulate the sensory nerves, thus producing pain relief. There are many contraindications and precautions when it comes to using TENS as listed on the slide. Before using TENS as a treatment, a sharp blunt test must be performed to determine if the patient can detect pain on the treatment site. So the case summarising is Edna Gray. She is a 67-year-old that is presenting with a 15-year history of pain around the right knee, with the pain getting worse recently. She has used TENS treatment in the past and she liked it. Aggravating factors involve gardening for more than 30 minutes, walking down inclines, sitting for long periods of time with knees bent, and ballroom dancing for more than 20 minutes. Easing factors involve lying down, gentle swimming, walking for 10 minutes. These factors indicate the pain is nociceptive or peripheral dominant pain. 24-hour behaviour includes being a little slow in the morning, but once she gets up and going, after a shower, she feels looser, and in the afternoon, the knee tends to stiffen up a little again. Edna's general medical history consists of high cholesterol, previous diagnosis of bowel cancer but no symptoms for 5 years, and a previous episode of depression and irritable bowel syndrome. Edna is currently taking Lipitor. There are also no red flags. Edna is retired and her hobbies include gardening, live theatre, ballroom dancing, and being a grandparent. Edna lives in a flat house with her partner. Edna would like to continue ballroom dancing, but knee pain is making her want to stop, and she would like to play and visit grandchildren interstate. I'd like to rule out the use of heat due to the contraindication of impaired circulation, which creates the inability to dissipate heat. This is because Edna has high cholesterol, which reduces blood flow, and is also taking Lipitor to prevent cardiovascular disease. Since impaired circulation is a caution for TENS, it would be an appropriate treatment option. TENS would benefit Edna as Edna has had a positive experience in the past, and TENS relieves both acute and chronic pain. Pictured on the slide are Edna's objective results. Improving Edna's right leg active movements and knee flexion is a goal throughout the use of TENS, with reducing her pain the main priority.